Welcome, everyone. We have the pleasure of having Dr. Lawrence Platt here with us today. Dr. Platt received his medical training at the Wayne State University School of Medicine and Sinai Hospital in Detroit, Michigan. He completed his maternal fetal medicine fellowship at the University of the Southern California School of Medicine. He remained on the faculty at USC for 14 years and left to be chairman of obstetrics and gynecology at Cedars-Sinai Medical Center and vice chairman of the Department of Obstetrics and Gynecology at the UCLA School of Medicine. After which Dr. Platt established a comprehensive prenatal diagnosis and ultrasound center with a close association with UCLA. This center is an active part of the MFM program at UCLA, residents and fellows rotating at the center. In addition, Dr. Platt has also held leadership positions for numerous professional societies, including serving as past president of AIUM and past president of ISHWAG, where he received the Ian Donald Gold Medal, the highest award given by ISHWAG. Dr. Platt has taught scores of fellows over the years, many of whom have gone on to be leaders in the MFM community and continues to teach fellows today. Today, he continues to be an internationally and nationally sought-after speaker, a peer reviewer of nearly 20 scientific journals, an author of more than approximately 350 peer-reviewed articles. Dr. Platt has penned 70 chapters in various medical textbooks and has authored 8 medical textbooks. As one of my mentors, it is a true pleasure to welcome you, Dr. Platt, to speak with us today about what you see as the synergy between ultrasound and cell-free DNA prenatal screening for chromosomal abnormalities, also known as NIPT and NIPS. So welcome, Dr. Platt.
Thank you very much, Kristen. It's an honor to be here with you today, and thank you for inviting me.
It's our pleasure. Dr. Platt, to get us started, can you provide some background on the evolution of ultrasound and prenatal screening for aneuploidies, where we have been and where we are going today?
I'll try my best. Certainly, we've seen ultrasound come a long way. If one reflects on ultrasound studies that really are integral to the value of ultrasound, I look back to one person study, Hugh Robinson study in late 1960s, when we had bistable imaging, where he looked at the crown rump length of the fetus the date of pregnancy. And we all know that dating has become such an integral part of what we're doing if we talk about nuclear translucency, which I'll get to in a minute. And those aspects of how big is the neck, relation to what size, what gestational age, you did it with bistable imaging. And today, with our sophisticated scanners that we have today, we've not disproven what he did way back in the 1960s with certainly an unsophisticated type of B-scan or bistable imaging. But when we move a little forward and we're really looking to what we can understand about nuclear translucency and evolution of how we can look at changes, I think there are a number of people who have really made a very big difference. Dr. Benacerraf, Beryl Benacerraf in Boston, at Harvard, at Brigham and Women's, Professor Kiplos Nicolaides, who is clearly probably the most prolific author in maternal fetal medicine, and fetal medicine particularly today, have really made the biggest advances when we talk about ultrasound and prenatal diagnosis in the area of the most common birth defect that we see in human, which is trisomy 21. And what Dr. Benacerraf did in the middle 80s was to notice that in the back of a neck at 20-week scan, an 18-week scan, it was thick nuchal fold. And she showed a relationship beautifully that the thick nuchal fold had a higher incidence of having a Down syndrome fetus. Not a one-on-one, but a risk factor. Remember, prior to this time, and thinking about it, amniocentesis was just first introduced in the 60s, late 60s, not even earlier than that. And we used to offer amniocentesis to women over 35, originally over 40, but then over 35. The false positive rate there was significant. But when you looked at the back of the neck and realized that that was not a same type of false positive, you lowered the risk, because there indeed is some risk anytime you do an invasive procedure. So Professor Benacerraf's contribution is certainly a significant one. Professor Nicolaides and the others that worked with him, Professor Rotem, and did work, and they were doing CVS, coronary villus sampling at the time, and ultrasound certainly is an integral part of invasive testing. Without ultrasound, the safety of these techniques would not be what it is today without it. The risk of CVS, even the ability to do CVS, would be more of a hit and miss. The same thing with amniocentesis. So the contribution of an ultrasound to do procedures, invasive procedures, pubs, fetal blood sampling, fetal transfusions, all these things that we're doing in fetal therapy is because of the advances in ultrasound. But what Kypros did, Professor Nicolaides did at the time, is looked and saw CVS patients, they had big nuchal folds and higher incidence of Down syndrome. He converted that observation to the test that we know was of combined biochemistry and nuchal translucency. Then I say that you could do the nuchal alone and realize that there's a risk. And indeed, if you had a large nuchal fold, you didn't need to look at the biochemistry. You realized that the ultrasound told you that you were going to have a higher risk of Down syndrome, and therefore an invasive test to get the karyotype would be indicated. And no doubt that is where we've gone with. We combine those technologies in more sophisticated techniques to measure small little millimeter differences that made a difference in risk for Down syndrome, and that's what Professor Kypros did, Nicolaides did for us. And I point out he did something else so extremely important when we realized, and that is he showed not only can you learn to do it, you have to continue an ongoing review of what you are doing. It has to be quality assurance programs that show that if you don't have quality assurance programs in NT, you make a lot of mistakes. You have a lot of higher false diagnosis, false positives, false negatives, and untoward outcomes come from that as well. So that combination of doing a test and then going on and making sure you have quality assurance program was another one of the landmark advances that Professor Nicolaides did in the area of prenatal diagnosis. Now, not all parts of the world catch on right away, and not all parts of the world believe the other parts of the world in their testing. In the United States, the National Institute of Health, NICHD particularly, sponsored an initial trial that Dr. Wapner, Ron Wapner was the principal investigator, called the BUN trial. It's biochemistry, ultrasound, nuchal translucency. And that study basically showed a higher sensitivity than our other tests that we used at the point prior to that, and as simply biochemistry, that you could identify Down syndrome better if you'd had the nuchal translucency combined with PAP-A and free beta HCG. Again, showing really credibility of what Professor Nicolaides has shown us earlier. Then the FASTER trial came in to look at combine not only the first trimester screen, but the second trimester integrated screen that also been talked about with the biochemistry markers. And again, as you see, the combination of biochemistry and laboratory testing and ultrasound, because really, what is ultrasound? Ultrasound is those of us who do ultrasound, it's our analyte compared to the laboratory's analyte that may be a biochemical hormone or maybe a molecular test that we're trying to do. So that evolution really is really guiding us to go forward to these types of testing that we have advanced from biochemical testing to observations, for example, and I give credit to Professor Erwin Merkatz, who took AFP, which we knew was a marker for neural tube defects, and showed that when you had that was when it's elevated, but if you had a low one, it had a higher incidence of Down syndrome. So anybody making these observations, follow them through and reporting them can make a very big difference, which is what each of these investigators who I pointed out have already done for us. So there's no doubt that when you look at these findings of changes in ultrasound, it's really helped us to really become the newest method to identify the fetus as risk, and particularly in this era of ultrasound advances, technology has helped us be more precise, lower our false positive rate, improve our detection, our sensitivity, our specificity in this whole area.
In your opinion, what is the role of the first trimester ultrasound today? Is it just about NT assessment?
Well, you ask a very important question. And I think if we start to look at first trimester ultrasound, I think, again, if you compared my first comment about Dr. Robinson in Australia when he used bystander imaging to diagnose the size, the age of the fetus. Then there was other studies, Professor Ian Donald, who really is the father of ultrasound, and work that he did along with Professor Campbell, who again is if Ian Donald is the father, maybe Ian Donald should be the grandfather, and Professor Hobbins in the United States should be the father of obstetrical ultrasound. They went on to start to say, take this to identify malformations. Anencephaly was the first that was recognized. So it's an evolution of our sensitivity and our resolution that we can make with these things. So there's no doubt that when we start to look at changes, and then this image that you see here is really an acrania or anencephaly that you have in this particular fetus on your left, with color showing some of the advances that we can do today with flow and looking at flow disturbances, and that's how we can make cardiovascular abnormalities. And mind you, we can see cardiovascular abnormalities in the first trimester on an anatomic scan. We can do it using high-resolution transvaginal imaging, and you can use it, as you see here in this transvaginal image with color flow, that you can see that the whole orientation of the vascular system of the fetus and recognize the difference. And in fact, as strange as it looks, because when you compare it to the two-dimensional one on your right, you can see that the brain material that's out, you have no idea to know what the vascular changes that are there, but you can see there's no skull there. And here on the left, when you see it, you can see that there's vascular flow that's disturbed vascular flow already in the first trimester that these advances are allowing us to do. So as we start on this image, we can go and look at the next image and see the changes that are there in what we can see in the first trimester scan. You can recognize that when we see this particular scan, you're seeing a two-dimensional image of a conjoined twin. See, 2 and 3D are complementary. Just as 2 and 3D are complementary, so is the other ancillary testing that we do today. I don't think we should ever think of one without the other. You know, the famous song, you can't have one without the other. I think very clearly we have to think about ultrasound as the property as it works together. And the same changes that we see here, you can see this, the follicle sitting here, large and follicle, looking at the vascular changes on the right. I think it's very clear that these images are exquisite. You can see that this can be done by any investigator, any sonographer. If you're putting the probe in your hand, you've got to be prepared to make the diagnosis. And looking at the first trimester, it's our responsibility not to put blind's eye on what we're seeing. Look for the most that you can see, and you'll make a difference in your diagnostic capabilities and in helping these patients get along a better understanding of where they are and what they can do with it. We can recognize other factors in the first trimester. So you're already seeing that you can see so many different things. This is a very interesting case. This is a case that I was sent because the, quote, other examiner couldn't find a nasal bone. Now, if you look closer, I've got a resolution very clearly of the 3D image of a proboscis. Well, you're not going to find too many nasal bones in a whole prosencephaly, I can promise you. So again, if you just look for one thing and you have targeted to do one thing and you close your mind to everything else, you're not going to make the diagnosis that you want to do. You have to have the complete look at the fetus and look at it as if you are trying to determine what else is going on, not just what someone sent me the image for. I mean, yeah, I could have said, yeah, there's no nasal bone, you're right. But that's not what it's about. It's how do you take from an image, how do you take from a scan and get as much information as you possibly can? And I think that's going to be a theme that I'm going to address a little later when it comes to where we're going in the future, because very clearly there are things that you can get at and think of that you should not close your mind to and open it to say, what can we learn about this and where do we go next? On the right side, you see an image of a really jugular lymphatics. I think it's very clear that you're seeing a change that will be there in a lot of fetuses. And I will assure you, if you're just doing transabdominal imaging, you're not always going to see it. You need that highest resolution, a high-resolution transvaginal imaging that really makes a difference. Now, do you need to do transabdominal and transvaginal imaging on everybody? Personally, I do in the first trimester. Does everybody? No, I'll tell you they don't. But you know what? I get value out of it. In that 12 to 14-week scan of where we're going, and you'll see what's happening with that, very clearly, I want to bring out as much as I can about that image and really start to think about, am I missing something? And as I said many times over, I have a busy practice. If I go home at the end of the day and haven't found malformation, I worry about this because we all can miss malformations. And so being careful, being diligent on every scan that you do is really important. Thinking about the things that you can witness in these fetuses. So it's not just the NT in the first trimester. It's really how the evolution of ultrasound in the first trimester has transformed the way we think about it. It's transformed what we can do. It's transformed of what what we should be doing. And in the United States, there's been a collaborative effort led by Professor Brian Bromley, also Brigham, an associate of Dr. Benacerraf, that put together a multidiscipline group together to put new guidelines together for the use of ultrasound in what's called the 12 to 14 week exam, realizing that if you really want to see the heart better, it's better a little later in the first trimester than at 11 weeks. And very clearly, we have recognized that it's not just about NT anymore, and it's our responsibility to look not just for the NT and not just for the fetus, but look for placental changes that are there. So the AARUM, along with the Society of Maternal Fetal Medicine, the American College of OBGYN, Society of Radiologists in Ultrasound, the American College of Radiology, the American College of Osteopathic OBGYNs, the Perinatal Quality Foundation in the United States have put together a new proposal that's now going through the societies, which has been now accepted by most of them. Soon this will be published, which is the newest guidelines for the 12 to 14 week exam that will include not only NT, but it will include anatomy, comprehensive areas of anatomy when possible. So very clearly, these new guidelines, I think, will be adapted. And if you compare what has been done at ISWAG earlier, and I give credit to the guidelines that ISWAG has put out, it's been far more stringent than what we had done in the United States. But I think now with the new guidelines in the United States, that it will approach and maybe even exceed those requirements that ISWAG has put out, which are outstanding guidelines for us to think about. But most important, it's not just a crown rump length. It's not just an NT anymore. It's really to help us integrate our understanding of fetal anatomy, fetal physiology, and probably the genetic components that we all think about in associations with these findings that we make in the first trimester.
With what we just discussed about the evolution of the first trimester ultrasound, what do you, Dr. Platt, think is the role of first trimester ultrasound in the patient care pathway, where NIPS is offered to pregnant women as a first-tier screening option for chromosome anomalies, especially given the newest guidelines from ACOG and SMFM? And how would you advise your local referring physicians?
Well, I think for some time we've published a lot of material on first trimester and a lot of data on NIPS, NIPT, and realized that we've often gone out on a limb and saying this should be offered to everybody. Like a lot of things that we do, including ultrasound itself, it took studies upon studies upon studies to say it's worthwhile. If you had focused on something, you'd realize it. There are those that don't think you should do an anatomy scan in the first trimester. It's not indicated. There are major centers that don't do it. They think it's only by indication driven. And that certainly has been the case with NIPT, where they fought it over the years. Having been fortunate to have worked with some of the development of NIPT, you saw the value, the importance of what this technology can do and the great potential that it had. And I, for one, am very pleased that Society of Maternal Fetal Medicine and ACOG have come up with their newest guidelines that revised the last one for 2018 that came out this late in August this year, that finally said NIPT or NIPS should be offered to every pregnant woman, as you pointed out. It's long overdue. And if you think about it, on the other hand, a lot of societies are slow in making policy. There's probably nothing that's been more rapid in changing policy than NIPT has had, because people have realized incredible value this has done for us. So I think, in my feeling, I think that the aspect of first trimester ultrasound plays a role in partnership with NIPT, NIPS. One, there are differences. There are differences in what you see. You see twins, you see triplets. There may be a vanishing twin. There may be fetal demise. There may be a major malformation. There may be something wrong with the placenta that you can see. There may be a molar pregnancy. So sending these things off, rushing them, you have to say, where's the cost-effective component come in? Which should go first? And I think it's not a matter about chicken and the egg. It's really about the combination of the two that are relevant to each other. If you can put all the information together, it makes a whole lot of difference whether you're dealing with twins or whether you're not dealing with twins, whether you're dealing with a fetal demise. It's not going to tell you. Or if you look at it early on and you see a major abnormality, your answer is it really going to be NIPT, or should you invasive testing? What are you trying to achieve? And if you see an abnormality, and we know the associations are there, as I pointed out earlier, you have a structural abnormality, you're no longer looking for a screening test. You're looking for a diagnostic test. And, as we go further and where this is going to head up in the future, maybe we'll have more of the diagnostic capabilities. But today, we still have to look at NIPT as a screening test. And it's a superb screening test. But I think if you have findings on an ultrasound early on that suggest a very high incidence of a aneuploidy or other chromosomal problem, microarray, et cetera, I think you may not want to do that NIPT and save that money for other aspects of care.
Now, along those lines, if we think about the evolution of NIPS through the years, much like the evolution of the first trimester ultrasound, in your opinion, what is the role of expanded NIPS, so screening beyond the common aneuploidies, in cases of that abnormal ultrasound like you highlighted, for those women who may decline invasive testing?
Well, if I had a crystal ball here, I believe at some point they're going to ask the question, what's an amniocentesis? What's a CVS? Did you really do those things? I mean, we already know people ask of a lot of things that we do. We can't believe that there was a time in management of healthcare and pregnancy that you did some certain things during procedures that made absolutely no sense to us today. I really believe that we will see that when it comes to NIPT as well, NIPS. If we look at evolution already today, in the first studies that I was involved with, the first cases that we saw, you saw that the sensitivity specificity was very different. As these tests got better, you had better efficiency with these tests. And if you didn't believe that, you made a very big mistake thinking of that. There's no question about it. And just as they argued, should you do these by age? Should you do these tests by high risk or low risk? Look at the change that just happened already. They finally admitted it's good in every pregnancy. It made no sense to me all along that you had to distinguish between high risk and low risk. There were a number of studies that were out there that showed the differences to be not significant between high risk and low risk. Why would you hold that back? Why would we want to do that? But when we look at the evolution of changes over time, listen, I think it's really clear. If anything that's moved faster, and I talk about high resolution ultrasound, I say the advances that we've seen in ultrasound has been spectacular. But it's when you compare it to the advances in molecular genetics, forget it. It's not even close. I think it's real clear when we look at that first ability and how many years it had taken to finally have this test come through that you can do it. They tried all these other research studies to get fetal cells maternal circulation, try to do it that way. And there are other ways that people are looking at it today as well. But very clearly, the evolution, the improvement, efficiency of these tests, whatever methodology one uses, we're going to go from detecting microdeletions in NIPS or NIPT to going, as you show here, to the expanded screen, to the whole exome, that the whole genome that will be there, that I think will have non-invasive testing. And so I think we're going to move in that area. I hope sooner than later. I hope people will understand that it will take studies to really show that. But the advances that are taking place are monumental. The next generation sequencing is here to stay. The next generation sequencing are really showing us dramatic advances, thanks to all the scientific advances that way. I have no doubt that we will be seeing the integration of these advances into clinical care sooner than later.
And Larry, what do you think is the role of ultrasound in cases of an abnormal expanded NIPS result?
Well, again, I think it depends. When we start looking at an abnormal result, NIPT, you have to recognize that patients have choice. Patients want information. I think that our first line is to look at a patient who has an abnormal NIPT. And I'll give you an example. An hour ago today, my last patient this afternoon was a patient who was told she has NIPT positive for trisomy 13. And what is the predictive value positive of that test for her? What was she given? She was giving 22%. Well, we know that we look at sensitivity of some of these tests, they're probably not as high as the trisomy 21. And so what do you do first? You do an ultrasound. And if you see a major abnormality, you kind of believe it, don't you? But if you see an absolutely normal appearing fetus, and I'm telling you a detailed scan, a normal appearing fetus, and this is a patient that may or may not want to have invasive testing, I'll get to that in a moment, that certainly is going to lower the predictive value positive of that test by having a normal ultrasound examination. So it helps in integrating information into the counseling. And again, I want to emphasize the genetic counseling is an integral part of what we're doing in all of this. It's not just my gut feeling, oh, why not do it? Why do it? You know, I come from a country, they do amnios in everybody. You know, I think informed decision-making is a real important part of what our responsibility is. The beneficence of patients is really theirs. The autonomy there has to make that decision. We're there as a partner with them to help them make this decision by providing them information, not by leading them down the line and telling them what to do. So I think there's no question that you have an abnormal test. We can find out, what is it? What's going on? Is there something going on? Is the fetus alive to begin with? There was a low fetal fraction. Okay, what's going on there? Is it twins? Is there things that are different that may make a difference? So I think it's really going to push the limits of what we can see in ultrasound and say to them that this trisomy 13 fetus had absolutely nothing on ultrasound. And I can tell you, I saw beautiful outflow tracts in the late first trimester. I saw certainly the free vessel view was beautiful. There was no omphalocele. There was no midline defect. The brain had the beautiful butterfly sign. There was no changes that I can see. The limbs were perfect. I saw the digits. I happened to look at all the long bones as now part of our new guidelines to pay attention to that, which I've done for some time. And I'm willing to say to you, this lady left today with a better feeling of hope. And mind you, I didn't guarantee her anything, better feeling of hope than anything else. And she's at a crossroad when would you do a CVS, real late CVS, or would you do an amnio? She preferred to have an amnio, and we'll do that a little bit later, but she went home with hope. So how does the first trimester ultrasound play a role? In a very important role. And like any test, ultrasound has false positives and false negatives. Currently, the biochemical tests have false positives, false negatives. The molecular testing that we do will have false positives and false negatives. We do know that the degree of those seem to be better in favor of the molecular testing than some of the others because it's not so much individual decision-making process. But again, as I commented, we're going into an era of artificial intelligence and machine learning that maybe our ultrasound will get even better and better with the aids of pattern recognition to do those things that we see. But I think it's an integral part. I think it's a very important part that we're looking at and will make a very big difference as we combine our ultrasound information to our prenatal tests that we have done.
Finally, what do you think might be the future synergistic roles of ultrasound, both the first and second trimester, and expanded NIPS? Do you have any thoughts on potential future societal guideline changes, especially since it's fresh on our minds from last week?
Well, yeah, I mean, listen, we've been waiting for that for a long time. We've been lobbying for a long time. I think the changes that have taken place, I think people are buying into molecular testing. I don't think there's any question about it. You know, who are the decision makers? And I won't get into the gender differences that may be there who are just decision makers, but very clearly, I think we're seeing the importance of molecular medicine. We're seeing the importance of personalized medicine that plays an important role, that we really individualize the care that we're doing, and recognizing first responsibility is first do no harm. That's our number one responsibility that we have, is do no harm to what we're doing. We want no misdiagnosis. We don't want any aggressive changes to make sure we can test every day. You can test everybody and cause some harm along the way. I think we're going to merge those technologies together to do everything that we can. I think that the molecular testing will prove to us to be an important part of our society guidelines. As we have, like anything else, it has to be studied, it has to be tested, it has to be evaluated, and also recognizing it has to be cost effective. We can't have disparity in what's available to our patients. If you think about the whole concept of you are what you were as a fetus, and I think very clearly that's where it's all coming from. And it's going to go that way with molecular testing as well. the concept of Barcroft in that the fetus life has an important role in what we're doing. Clearly, a lot of these potentials are there from early on, and we're going to see these markers. And whether it's a cancer marker, whether it's a disease marker, we test for those all the time, don't we? We're just at the tip of the iceberg, and we're going to see so many more things come available to us as we see the evolution of changes in how we define our testing, what we think our experience has been, and going down that line from this first NIPT, we can tell Down syndrome, we can tell trisomy 13, we can tell trisomy 21, to look at the 5 or 6 or 7 microdeletions that people are looking at, whether it's 22q11, whatever it may be, to the next phase, to do a whole exome, to do a whole genome, to do whatever we can do going forward. It's going to happen. We just have to be receptive to it. We have to study it first and show it. We have to bring the cost down so that we can make the NIPS accessible to everybody, so we have no disparity in healthcare, which I think is a responsibility of all of us who are in advanced phases of medicine.
Dr. Platt, thank you so much for your time, your expertise, and the valuable discussion. We truly, truly appreciate it. Thank you.
Thank you very much for having me, and always a pleasure.